All right, I'm going to introduce to you our last speaker of the day. For our last speaker, we have Dr. Michael Hoffman, who's going to be presenting on orthodontics and dental facial development. It's kind of my honor to kind of introduce Dr. Hoffman. Him and I go back to our days in undergrad, where he was the president of our pre-dental club, and our paths have crossed many times in the Army Dental Corps. And Dr. Hoffman's a great speaker, graduate of the Army Comprehensive Dentistry Training Program. And overall, he's going to give you a great talk on orthodontics and dental facial growth. So without further ado, Dr. Hoffman, the microphone is yours.
All right. Well, thank you, Mike, for that great. Thank you, Mike, for that great introduction. Also, an honor to be lecturing with you, even though from far away. So, good afternoon, everybody. I know I'm the last thing standing between you and freedom, so we'll get going here. Pretty short section, both on the test and what I'm going to be going through. So, there probably are more specifics in this lecture than what the test is going to touch on. So, I'm going to probably throw a lot more info at you than you're going to need, but I think that's always better to be well prepared. So. Again, I don't have anything to disclose here. I probably won't be talking about any products in this lecture. And then just thanks to Dr. Einhorn and Dr. Scarapati for their previous work on this lecture. So getting right into it, let's talk about stages of dental development. So first of all, we have our gum pad stage, which occurs from birth until eruption of the first tooth, which is going to occur right around 6 or 7 months. That's followed by our primary dentition stage. And that's marked by the eruption of our first primary tooth, and that continues until our first permanent tooth erupts. After that, we have our mixed dentition stage, which is marked by the eruption of the first permanent tooth. So our 6-year molar, which is easy to remember at 6 years of age, normally. And we stay in mixed dentition until we've exfoliated all of our primary teeth, and that's when we begin our permanent dentition stage. So we'll talk a little bit about normal development and eruption of primary teeth. So you know, whenever you see tables like this, and it can be kind of overwhelming, I think the big thing here is to just look at patterns. When we talk about eruption of both primary teeth and adult teeth, patterns are super important. And then age ranges. You know, I like to say a lot that we can't put kids in boxes. You know, they aren't always going to develop on the same timeline that the textbook says they should. So knowing age ranges, roundabout ranges, and then the order of things, I think is much more important than remembering exact timing. So tooth formation is normally going to begin at about 7 weeks in utero, and by about the 4th month, we're starting to get mineralization of the tooth. We're looking at eruption, so mandible is usually going to be a little bit ahead, followed by the maxilla, and that tends to occur throughout both primary dentition and maxillary. So we're going to have our central incisors first, followed by our laterals, then our canines, our first primary molars, and then our second primary molars at about almost 2 years of age. So again, here's these normal eruption patterns. Again, look at the patterns and roundabout time periods. So again, mandibulars first, followed by our maxillaries. Yeah, correct, our maxillaries. So they're just kind of good rough numbers to know. So let's talk a little bit about eruption sequence again. So this is another way to think about things, and this is how I often do it for test taking purposes. So when we think about Palmer notation, and that's how orthodontists talk about teeth, they letter the primary teeth. So our A is our central, our B is our lateral. So if we're talking about number 7 or upper right lateral, that's an upper right B. Our first primary molar is our D, our primary canine is our C, and our primary second molar is our E. So for our eruption sequence for primary teeth, it's AB, so our central and our lateral, followed by our first primary molar, and then our first primary canine, and then finally that primary second molar. So A, B, D, C, E is a good way to remember these things. And again, remembering that our mandible is usually going to be before our maxilla. So a couple of things we'll talk about in primary dentition. First of all, spacing, both our primate space and our leeway space, a little bit about incisor liability, and then we'll get into molar relationships. So primate space, or our canine space, is something that we're looking for in kids. So we want kids to be very, what I would say, gappy, or see a lot of spaces. So parents may not love this, but this is what we want to see. So it's normal to have this kind of spacing in the primary dentition. 87% of the time in the maxillary arches, it's going to be distal to the lateral, and 78% of the time in the mandibular arch, it's going to be distal to the canine. So if you're asked to identify where the primate space is, the canines are usually going to point to the opposing primate space. So when we look at our maxillary primate space here, our mandibular canine is pointing to that space. When we look at our mandibular space, you can see that maxillary canine is pointing to that space. So that's kind of the cheat to figure out where that is. So what about incisor liability? So our permanent teeth are going to be a lot bigger than our primary teeth. So in the maxillary, they're about 7.5 millimeters bigger than our primary incisors, and our mandibular permanent incisors are about 5 millimeters bigger. And that's where that spacing, that primate spacing, is important, because we need to have room for those permanent incisors to come in. So you can imagine if all those teeth are nice and straight in the primary dentition, there may not be room, even with growth of the mandible and maxilla, for those permanent incisors to come in. So that incisor liability is that difference. So let's talk a little bit about leeway space. And the leeway space is basically the total sum of our primary molars, the difference in those, and the total sum of the size of our permanent premolars. So in our maxillary arch, that's 3 millimeters, or about 1.5 millimeters per quadrant. In our mandibular arch, it's 5 millimeters, or about 2.5 millimeters per quadrant. Also want to talk a little bit about E-space, which is related to leeway space. And that's the space formed by our E's. And that's, just as a reminder again, our second primary molar. So if the E is lost early, your sixes, so that's your 6-year molars or your first permanent molar, can drift in and close that space, something we call late mesial shift. And not just loss of the E, but also gross interproximal caries can also cause movement of the teeth in the primary dentition. So a bombed out primary molar or early loss to trauma, we can lose that E space, and that can be a problem, okay, with this late mesial shift, and I'll talk about that. So let's talk a little bit about our primary second molar relationships. So if you're familiar with Angles class, this is kind of like our pediatric Angles class. So first of all, we have our distal step, and that's kind of a class 2 tendency, and we're going to see that in about 10% of kids. Next, we have our flush terminal plane, or our class 1 tendency, and that's in about 76% of kids, followed by our mesial step, which is more of a class 3 tendency. We're going to see that in about 14% of kids. So let's look at this a little bit more closely. So here's our relationship. So when we look at our flush terminal plane, think about the distals of those primary second molars. They are lined up or flush, okay? And that's where that term comes from. Our mesial step, you can kind of see we're stepping down to the mesial here. So that lower primary molar is a little bit more anterior. That's more like a class 3, like a pediatric class 3 almost. So the mesial step kind of steps down towards the mesial. Our distal step, or kind of our pediatric class 2, if you will, that step goes down to the distal here. So you can see how that's going that way. And that primary molar on the mandible is a little bit more posterior. So you can think of more like a retruded jaw. So the reason these are important is these are going to tend to develop a certain way, both based on how the child grows, that's going to be part of it, and then shifting of teeth. So our distal step is normally going to become either a class 2, or with some growth, it could become an end-to-end occlusion in their adult dentition. Our flush terminal plane could stay end-to-end, or with late mandibular growth, we could get a class 1 occlusion. And then our mesial step is either going to develop into a class 1 or a class 3. So why is that important besides for taking a test? Well, you know, if you're examining a child, we can kind of talk to the parent about the things to anticipate as this child grows older. So, you know, now you can start talking to them early on if their child is going to be a candidate for braces. So let's talk about mixed dentition. So that's marked by the eruption of our permanent 6s until all of our primary teeth are exfoliated. So again, chart, lots of numbers. So let's just think about patterns here. So the first one that's going to erupt here in our permanent dentition is our first molar. So our mandibular first molar and our maxillary first molar at about 6 to 7 years. Then we're going to go to the mandibular central and the mandibular lateral, and our maxillary central and maxillary lateral. And then things get a little weird here. Next, we're going to have our mandibular cuspid or canine at 9 to 10 years, and our mandibular first premolar. Then on the maxillary, we're going to have our maxillary first premolar and second premolar. followed by our mandibular second premolar, then our maxillary cuspid is going to come in, and followed by our maxillary and mandibular second molars. So again, there's probably an easy way to think about this when we think about our Palmer notation. So eruption sequence for Palmer. So in adult dentition, we go from lettering to numbers. So 1 is our central, 2 lateral, 3 canine, and so on. So for our mandibular, our 6s are going to erupt first, our permanent molar, followed by our central, lateral, and canine. First premolar, second premolar, second molar, and then third molar. So the mandible is pretty straightforward. Just always remember that first molar is going to erupt first, and then everything else is going to go in order from the central all the way to your third molar. Now the maxillary is a little bit more tricky. Okay, so the number for this one is 6124537 So we're going to have eruption of our molar, our first molar, then our central and lateral, and then the first premolar is actually going to erupt, then the second premolar, and then our canine is going to erupt, followed by our second molar and third molar. So what's normal? So I think it's really important for kids to remember in kids that variability is very normal. Again, like I said, with the leeway spacing in the anterior dentition, that is normal and we want that. Asymmetries are also very normal. So, you know, if our right upper lateral erupts and that left one's not there, it can be up to 6 months behind. So that's normal in antemeres. And then having a temporary open bite is also a normal finding in children. So let's talk a little bit about ectopic eruption. So this is a tooth that's erupting in a place that we don't want it to be. So as far as incidence, our molars, we're going to see this most often, followed by incisors and then canines. Now, 60% of all ectopic molars will self-correct. So we see this situation here. We have this maxillary 6, or this maxillary first molar, starting to resorb the primary second molar. And why is that bad? Well, if we lose that root structure from resorption, then we're going to lose that tooth early, and that 6 can drift into that space and block out our premolar. So it can be an early indicator of crowding, and that's why it's good to get some screening radiographs, and this would be seen on a bite wing normally to look for these sorts of things. So what are some ways that we can de-impact that? So here's 3 pretty common ways. I'm going to talk about the orthodontic separator because that's something you may actually use in your practice, but brass wire placed in the contact can be a treatment option, and then a Halterman device, which is actually a fixed appliance that they use to distalize the molar. So this orthodontic separator, this is something you can do. If you've got an orthodontic elastic, just tie some floss on it, like that upper right photo. You'll stretch it, drop it in the contact, and then just make sure you monitor it. So the force from that little donut there is actually going to distalize that molar and help correct that situation. So if this is caught early, this is a super easy fix that can save the child a lot of problems down the road. Now, what about canine impaction? So this is why Panorexes are a great screening tool. So this study came out that kind of showed that there was an 87% chance of impaction if your cusp of your canine is past the midline of the lateral. So you can kind of see that diagrammatically on the right there. And I'll kind of show you here. So if this is the midline of the lateral, you can see that canine is quite a bit past that. Okay, so very, very good chance for this patient to have an impacted canine. So why is it important to catch that early? So if we catch this while the canine's root is still forming, we still have some eruptive potential, and we can correct this. So if you get this to the surgeon or the orthodontist, or if you're the one who's going to do this and you're going to expose this canine, we can do that sooner while there's still some eruptive potential in the root, versus if the root's all the way formed and we're trying to bring canines into the arch, we can resorb other permanent teeth, or it may stall out and we may never actually bring it into the arch. So really important to catch these early. So let's talk about space maintenance. So we're going to go back to our leeway space. So like I said earlier, you can lose space due to trauma. Caries, again, interproximal caries, we can get space loss from that, and extraction. So anterior teeth, like I said, space maintenance generally not needed. If we lose a unilateral primary molar, band and loop, crown and loop, and distal shoe are all treatment options, and I'll talk about those specifically. If we lose bilateral primary molars, a lower lingual holding arch or Nance appliance are good options for us. So band and loop. So we're missing a primary first molar, and this can either be done chairside or in the lab. And I'll show you the chairside one later on down the road. But in the lab, we'd have to fit an orthodontic band on that primary molar, take an impression, send it to the lab, and then they solder that band on there. So that can be kind of hard for some children, but we want to do it right away because we're going to get space closure in the first couple of weeks. So again, from that picture, you can kind of see there that band is going to hold that space until we exfoliate that primary molar, but that'll keep that space for that premolar to come in. This is the crown and loop. Again, you're going to need lab support for this. So perhaps that tooth had large caries and we're putting a stainless steel crown on it. We can actually solder a band onto that stainless steel crown instead of having a band and loop. You can do a band and loop over a stainless steel crown as well, just something to keep in mind if you're seeing these types of patients. And that would be a little bit easier in a situation where you may not need, if you needed to do that stainless steel crown or the tooth was lost later. So distal shoe. So this is used if we lose a second primary molar, okay? And so what we do is we end up putting a band on the first primary molar, and then this distal shoe, which is sort of a blade that goes to the distal here. We have to anesthetize the patient, and then this blade is placed below the gingiva to guide the molar into place. So something else I wanted to point out here, you can kind of see radiographically, this is we call it de novo. It's kind of like a trombone. So the band already has these little sleeves on it, and then this can come in and out to adjust, and then you take some pliers and crimp it. So this allows you to do something chair side, you know, maybe like an OR case, or if you are doing these and you don't want to bring the patient back for behavior or whatever, you can do this. You can do your extraction and place this distal shoe. Really important to take a radiograph to check it, because you can imagine if this is not placed properly, that first molar will not guide into place and could actually get blocked and not erupt in time. So what are some of our contraindications? So essentially we're placing an open wound here in some ways. So we don't want any bleeding disorders, no SBE or subacute bacterial endocarditis. Uncooperative patients are another one, because you're going to have to numb the patient up for this. And then if the 6 is already erupted, we don't need to do this. If the 6s are erupted in an occlusion, we don't need to do this type of space maintenance anymore. So what if we lose molars on both sides? So on the maxilla, we have this Nance appliance. So essentially, we're placing an orthodontic band on the most distal molar. Now in this situation, we're on adult molars, but you can place it on that primary. This says we need to have our 6 erupted, excuse me. So this is placed on the permanent molars, and then there's this little acrylic button on the palate. Okay, so one of the problems with this, as you can imagine, is food can get packed into that button, and there can be hygiene problems. But this can help us bilaterally keep the space. Now, there's nothing wrong with placing a band and loop bilaterally, you know, doing 2 single appliances, but some people find it easier to place this single appliance to save space on both sides. Next, we have our lower lingual holding arch. Again, we're preserving our leeway space. We need the 6s to band to. Now, the other important thing with this, our permanent incisors usually erupt kind of lingually, so we cannot use this appliance if we still have primary incisors, because we could block out our permanent incisors if that loop is up against those primary incisors. Okay, so very specific case you'd have to use this. Again, you'd have to have your 6s, and you'd have to have all of your permanent lower incisors. So I'm going to talk a little bit about serial extractions. So these aren't done all the time because it's a very specific patient that we can do these on. So what we're basically trying to do, we have a patient who has anterior crowding, and we're trying to shift that crowding from the anterior to the posterior, what some people call robbing Peter to pay Paul. So we're doing that by taking out that first permanent premolar before the canines erupt, so that we can move all that crowding more distally. So again, very specific patient that we're going to do this in. They have to have class 1 occlusion with a normal overbite and overjet. Skeletally, they need to be a class 1. They need to be in their mixed dentition. And we have to have severe dental crowding, so greater than 10 millimeters of crowding. So this is kind of the steps. I'll kind of briefly cover these, but we're going to pull out our primary canines, our Cs, early to allow for our permanent lateral incisors to come in first. Next, what we're going to do is we're going to extract that primary first molar as soon as the first permanent premolar's roots are 1/2 to 2/3 formed. So we need to make sure that we have permanent premolars. And then once those roots are at that point, we know we still have some eruptive force. We're going to extract that primary molar to speed up the eruption of those premolars. Once those are erupted, the fours, that first permanent premolar, we're going to extract them to allow our permanent canine and second premolars to erupt. Now, even after doing all that, we may need to do full appliance therapy to finish the case. And it's super important to take diagnostic radiographs, especially at pano on this patient, to make sure that we have all those premolars present and that they're developing properly. Because if we start extracting teeth and we don't have a succedaneous tooth for it, we're going to be in trouble. A little bit about thumb sucking. So non-nutritive sucking is normal but can lead to malocclusion. So it's usually when patients keep this habit into the next dentition and then they continue to suck their thumb for long periods of time during the day, so 6 hours or more. So some of the problems, and you can kind of think about this if you think about the space that the thumb would take up as it's in the child's mouth. So we're going to get flared maxillary incisors. Our lingual incisors are going to kind of get pushed down and pushed lingually. We're going to end up with an anterior open bite and then often a narrow palatal vault. So adult dentition. So let's talk about angles, molar classification, and then profiles. So we'll go back to dental school here and we talk about our class 1, class 2, and class 3, okay? So again, we're looking at, in our class 1 situation, the mesial buccal cusp of our maxillary first molar should fall into the buccal groove of the mandibular first molar. And this should be our most common. And this says malocclusion. What they're talking about when they say malocclusion is we have a molar relationship with class 1, but our anterior teeth are a little bit crowded. So class 2 are a little bit more retruded. Our mesial buccal cusp is going to be mesial to our buccal groove. So I'm thinking that mandible is more distal, all right, is how I like to think about it. Within class 2, we also have div 1 and div 2, and that's kind of describing our incisor inclination. So when we think about our div 1s, very proclined, lots of overjet, and a deep overbite. They're going to typically have a very narrow palate. They're going to have some lip incompetence because they're going to have a shorter upper lip, and their mandible may be very deficient, kind of look undeveloped. Our div 2, our incisors are a little bit more lingually inclined or lingual inclination. They're going to have a very deep overbite, but a little bit more of a broad upper arch. Their lip is going to be normal, and the mandible is going to be normally of a normal size. And then finally, we have our class 3. So our mesial buccal cusp is falling distal to the buccal groove, meaning that mandible is kind of more forward, and they're often going to have an end-to-end anterior bite. So then we also want to talk about dental versus skeletal, because those can be kind of different, what our angle classification is versus a true skeletal classification. So we have our class 1, kind of normal, and that's kind of our straight on profile that you would see in the middle in B there. Class 2 is going to be a little bit more retruded skeletally, and that's going to give us kind of our more convex profile. And then we have our concave profile, which is our class 3 skeletal. So really some basic science in terms of tooth movement. So when we're applying an orthodontic force, we're talking a lot about tension and compression. And so in our area of compression, we're going to have decreased blood flow. In our tension area, or where there's strain, we're going to have increased blood flow. That's going to cause some inflammatory markers and chemical messengers to be released. And essentially what's going to happen on our tension side, we're going to have bony deposition. So our osteoblasts are going to lay down bone. On our compression side, our osteoclasts are going to be activated, and we're going to get resorption of the bone. So as the tooth is moving along the bone, what's actually happening is everything in the compression side where it's being moved towards, bone is being removed, and trailing that, bone is being added. So types of orthodontic movement. So first of all, we have tipping, which is when we have a single force applied to the tooth, which rotates around its center of resistance. We have translation, which is kind of two forces causing bodily movement. So it's bodily moving through the jawbone. So our PDL is uniformly loaded. Next, we have root uprighting, or what orthodontists often call torque. So the crown is going to remain stationary, but our root is moving. So we're trying to get root parallelism. Rotation, kind of self-explanatory, but the force is going to occur around the center of the rotation as we turn something. Extrusion, so that's like controlled eruption. And what we're doing is we're placing tension on the PDL to bring the tooth more coronally. And then intrusion, which often takes light forces because we have a lot of forces on a very small surface area of the apex of the root. So those small forces to intrude the tooth. So very light forces in that situation. Very briefly here, clear aligner therapy. I think we're all kind of familiar with this. I'm not going to talk about specific brands, but I'm going to kind of get into the basics of it. So force plus space plus time is kind of how we get tooth movement. So physiology is the same, whether we're using brackets or we're using aligners. So with aligners, we have a thermoplastic material and then some attachments bonded to the teeth, which provide both retention and activation. So the elastic deformation of that material is what's giving us our force. So aligners need to be in for about 22 hours a day. And then based on the treatment plan, we're going to be changing aligners every 1 to 2 weeks. So what are some of the benefits of that? Well, aesthetics is one. Reduced risk of decalcification. It's easier for the patient to clean their teeth when they take the retainer out. Some thought there's some decreased abrasion from parafunctional habits. These are really good for positioning teeth in limited ortho for proper placement of restorations. And the nice thing is we don't really need a lot of instrumentation to use these. So limitations, so a couple studies talk about, so Graber says, it's kind of difficult to control root torque and root parallelism, as well as rotations and extrusions with these. And Prophet talks about how it's hard for high canines and molar uprighting. It can be hard to correct a posterior open bite, and they may still sometimes require braces to finish. Because a lot of these are proprietary, they can be expensive to both the dentist and the patient. And so I think you're starting to see a little bit more DIY from companies like Blue Sky Bio. They're difficult to use with extreme crowding and patients with severe skeletal discrepancies. And I think the biggest take home for this is they're removable. So I think the biggest drawback is that compliance can be a real problem. So real quickly, I'll talk about TADs. So TADs are temporary anchorage devices that give us skeletal anchorage. They're very similar to implants, but they're not going to osseointegrate. So when we talk about in ortho, Sir Isaac Newton's, for every action there is an equal and opposite reaction. When we place force on a tooth, all the teeth in that orthodontic system are having force placed on them. So even though we're trying to retract maybe some incisors, the molars that are being used for retention are also going to have force put on them. So by using skeletal or absolute retention, we kind of can put all that force more efficiently just on the teeth. So these are really good for intrusions or extrusions, retracting teeth, very good for molar uprighting. And then if you're doing rapid palatal expansion, you can actually place some bone anchors in the palate and use it for that as well. So ortho relapse, 10 teeth don't want to relapse in the direction they came from because the PDLs have some elastic recoil. Also forces from the lip, tongue, cheeks can be kind of strong and place forces on the teeth too. So after ortho, the first part of ortho, we want to put them in full-time retention for about 3 to 4 months to allow those fibers to reorganize. And if you had a lot of crowding, you may want to leave them in retention for up to 12 months. So as one of my orthodontists say, you want to keep them in retention for as long as you want their teeth to be straight. So that may mean nighttime for lifetime. It's recommended that you kind of overcorrect and then plan that there's going to be some relapse or rebound. Fixed is good in some cases, especially in large diastema closures. Patients who have like lousy compliance, but hygiene can be an issue, and we probably know this. Many of us have probably seen a bonded lingual retainer covered in calculus. So also some removable options, Hawley retainers, you see on the right there, or an Essex, like a clear retainer. All right, that being said, and I'll take any questions at this point.
Okay. Let's see. The first one was ectopic eruption. How often should a patient with an ortho separator be seen for monitoring?
Yes, we should probably be seeing them weekly for monitoring.
Okay, next question. When you do remove the space maintainer, for example, for band and loop, when the permanent tooth first starts to show through the gum and when it has erupted more.
Can you read that to me one more time, Chris?
Sure. When do you remove the space maintainer, for example, band and loop, when the permanent tooth first starts to show through the gum or when it has erupted more?
So you probably want to take it out sooner than later because you don't want to block out that premolar either. So at the first signs of eruption when it begins to show through the gingiva, or if you've noticed it on a radiograph that it's going to come through, it's safe at that time to remove the band and loop.
I've noticed a trend in the past 5 years whereby orthodontists don't include permanent second molars in braces treatment. Almost inevitably, my patients end up complaining of malpositioned seconds, resulting in gingival defects, cheek biting habits, etc. What is guiding the decision for orthodontist treatment planning when it comes to disregarding second molars?
So I haven't seen that. I'm not really sure why that would be. Normally you would go to a second or first molar just for the retention, like I talked about with the TADs. You want to get a lot of retention, so using a first or second molar. I'm not sure why they're not doing that. My guess may be that might be more difficult for their tech to band that, or it may be hard to get a band or a bracket on there. But I'm not really sure why they would be doing that.
How long can you wait after extraction before placing a space maintainer?
So some people would argue you do it right away. So, alginate can get bloody, that's okay. Remember, I didn't talk much about behavior management, and I didn't follow that lecture, but, you numb up a kid, you really don't want to have to try to do that a lot of times after that, So if you can you've done your extraction, you place your band to see what the size is, and then you take your alginate at that time. Again, a little bit of blood's not going to ruin it's not like PDS. So it doesn't have to be quite as accurate as Crown and Bridge. So you can take it immediately. If you have a good kid with good behavior, you could bring them back as well in a week or two, but you're already going to start getting movement. So sooner than later is better.
Serial extractions are with mandibular ? Extract primary canines ?
So I'll bring that slide up because I know we're short on time, so I had to really kind of go through that quickly. Can you read me the question one more time, please?
Sure. Serial extractions are with mandibular ? Extract primary canines ?
Okay, so primary. And let me see if I wasn't clear on the slide here. Let me just read over this really quickly. So I think it probably depends on where you're trying to move the crowding. Again, this is not something that I do very often, well, ever, to be honest. But yeah, so I don't think it depends on which arch you're trying to gain that space in, if that makes sense. So if you have maxillary crowding, then it's the primary maxillary canines that you're working on, or it's the mandibular.
Time of intervention to stop thumb sucking habit.
So I didn't really talk about that much. So timing off the top of my head, I have to think about that for a second. So, but I think the big thing that's important to remember is that a lot of it's about behavior management. So especially like positive reinforcement, giving rewards when they're not doing that. So what else with that? So there are some appliances that you can use, but compliance of those can be pretty bad. You have to look up the timing on that for you. But once you start getting into the mixed dentition, so really around 6 years of age, if you're talking about mixed dentition, then it should be ending around that time.
So Dr. Hoffman, Dr. Kroll has some information on the why not to include second molars.
Oh, okay, yeah.
So Dr. Hoffman, yeah, so just to address that question, I know it's a trend a lot of people see with orthodontists not including second molars. I posted a link to Chris, and I don't know if she can post that link to anybody else, but essentially it's a kind of an editor's panel of the Journal of Clinical Orthodontics, talking about forgetting the second molars and why some orthodontists do and some orthodontists do not. The short answer to that is when it comes to a high angle patient, especially a young patient that has a high angle or open bite tendency, anytime we include the second molar without a temporary anchorage device or headgear, it runs the risk of auto rotation of the mandible and iatrogenic anterior open bites. So usually on younger patients that got ortho very early on for minor cosmetic reasons, alignment for a class 1 malocclusion, orthodontists will skip the second molar in order to avoid bite opening, high angle tendencies, and auto rotation later in life. So, but there's an article that I put on there. I don't know if Chris can send it out to everybody, but it's just a little kind of bit of an insight.
So I just posted it under the person who asked the question, and I made it public to everyone.
Okay, excellent.
So the next question, I thought class 1 occlusion is straight profile and class 2 occlusion is convex.
Did I not? Let's see, let's go to that. That's correct. Let's see what I said. So these two pictures don't line up. And I think that may be where it's confusing. So I apologize for that. So on the bottom, it's going class 1 through class 3 in the diagram there. On the top here, that concave, your class 2 is actually the first one you see. They put the class 1 in the middle and your class 3 is on the far right. So I apologize. That is a little confusing with the diagram there, but you're correct. Your convex is your class 2. Your straight on profile is your class 1.
Are TADs better than carrier distalizer for distalization?
Are TADs better than, can you say that appliance again?
Are TADs better than carrier distalizer for distalization?
I'm not familiar with carrier, that appliance that question asker is asking. So I have to look into that.
On the second to last slide under ortho relapse, is it suggested that retention is only needed for 12 months if severe malocclusion?
So the full-time retention. So we've taken our appliances off. I'm talking a little bit more about traditional ortho, not necessarily clear aligner therapy, but we've taken our appliances off. Now the patient's wearing a Hawley or an Essex retainer. So yes, 12-month full-time retention is recommended if the teeth were severely crowded.
For maxillary and or mandibular expansion in a teen, is fixed or removable better?
That I don't know off the top of my head for maxillary expansion. And that's not really within the purview of this, but yeah, I don't know really how to answer that.
Any options other than band and loop for non-compliant children or where it keeps coming off?
So if they're non-compliant, so two things here. One, hygiene. If their hygiene's atrocious and they're not taking care of this thing, we don't want it in there. We'll just deal with the crowding later. Okay, the caries and disease control is way more important. If it's a non-compliant patient, this is elective treatment. So if you don't think that they're going to be able to take care of the appliance, they're going to break it, or they're not compliant, we've got to medicate them and sedate them to place this, then it's just not worth doing. So that's why I was saying a pediatric dentist may, if the patient's already sedated, that's why a lot of times they'll do a chair side like the de novo, so they don't have to bring that patient back. But it's not worth fighting a patient to try to deliver that and have a bad dental experience for something that's pretty elective.
How common is a class 2 modified serial extraction sequence? Extraction of second premolar and first premolar.
I am not aware of that. Like I said, the situations that I was talking about would only be a class 1 patient.
What age do you recommend for orthodontic evaluation? Do you wait until all of their primary teeth have exfoliated?
So I tend to, so mixed dentition is a good time to start talking about an orthodontist. So I think I've seen a lot of patients that were kind of found too late, and then we have to do some other things. So one of the things we want to think about is like growth potential. So if we can modify growth with palatal expanders, headgear, things like that, we want to do that earlier than later. Some kids that are really, really bad we need to get intervention right away. So that's why like knowing about primate space and things like that, we can start talking to patients' parents early. Your kids' teeth are close together, there may be some spacing issues in the future. And then once probably they're into the early mixed dentition, that's probably a good time to start talking about orthodontics. There's a lot of other things that have to like go into that with the patient themselves. Is this patient a patient that's going to be mature enough to handle braces? Do they want braces? So, like I said, we can't put kids in boxes. I think you have to take each situation one by one, but I think for a more simplified answer, so early mixed dentition and a kid that has the mental maturity to keep the hygiene up and stuff like that. I think that's probably when you'd start doing it. But the earlier we catch these things, the better.
Do you fabricate the de novo appliance at the time of the EXT?
That's the question?
Yes. Do you fabricate the de novo appliance at the time of the EXT?
Correct. Yeah. So the de novo, it comes in a kit. Like I said, I don't have a picture of it, but it looks like a little bit like a trombone. Pedodontists like to use these up in the OR a lot because the patient's been put to sleep. We're not going to put them back to sleep to deliver this thing. So the box would come with your different sized ortho bands, and you fit the band, and then again it slides in and out, and then once you get to the size, and I don't know if I said this, but yeah, it's at the time of the extraction. So you extract the tooth, you fit your band, you'd adjust the de novo, and then you'd crimp it. So one of the drawbacks of these is they break, but you're trading off an appliance that may not last very long, that the child can break, versus bringing them back for multiple appointments. So again, that's a case-by-case situation when you would use those. But to answer the person's question, yeah, you would do it at the time of the extraction.
So Dr. Kroll provided some information that the American Association of Orthodontists recommend that a child's first checkup with an orthodontist be performed when the orthodontic problem is first recognized, but no later than age 7. Okay. So next question, how did you manage kids with severe long-term grinding and clenching?
So this question came up last time. So, kids are growing pretty quickly. So using like an occlusal splint. So first of all, I want to say bruxism in children is very normal. And as we're learning more, and this is a little bit outside the purview of this lecture, but as we're learning more about sleep disordered breathing, there's a lot of thought that it's related to pediatric sleep disordered breathing. So if you do have a child that is bruxing quite a bit, you may want to get that child evaluated for sleep apnea and get that with the primary care manager, and then move on to an appropriate medical provider. That being said, again, bruxism is pretty normal in children. You see it a lot. But again, because they're growing and things like that, we don't want to limit their growth by putting an occlusal splint in or limit their airway. So I think that's a conversation you need to have with the parents. But I think, like I said, in my mind, as this is becoming more known, I think it's probably more a sleep disordered breathing problem than anything.
Do you have a preference for the type of space maintainers used for both upper and lower arches?
So when I was doing this, I haven't treated peds kids in a while. I do like the band and loop. It's part of it's just what I had in my clinics. I've only done one Nance, and the hygiene problems, I totally had those with that child. And then she was always playing with it. So most of the patients that I saw, I didn't need to sedate, and they were very compliant. So it was easy for me to do a band and loop on each side if I had taken out 2 primary molars. So the band and loop was kind of a workhorse for me. I've never had to do a distal shoe, but that would be an option that I would use as well if I needed to, but I never really have had that situation.
What are some indications to involve speech therapy before orthodontic treatment starts?
I have not really dealt much with that. I can't answer that really well.
Does eruption of wisdom teeth cause crowding of anterior teeth?
There's not a lot of good evidence to support that. So over time, our mandibles constantly grow, our teeth are always moving. Crowding in the anterior is often normal, and there's, like I said, not really good evidence to support that wisdom teeth are actually causing that crowding.
TADs do not osseointegrate. Is it because they are not coated and because of the constant forces?
That's a good question. So some of it's in that initial part of the cortical bone. I don't think it has anything to do with surface treatments. TADs are very, very, very short. I wish I probably should have put a picture of a full one up there, but they're pretty small. Normally when you place one, again, oftentimes they get placed with the gingiva too. So other than that, I don't know how else to answer that question, but they really are only going into the cortical bone. And I don't know if that force that's being placed on them has anything to do with that osseointegration.
How long should clear aligner patients be on Essex? Lifetime, nighttime?
Correct. So again, whether it's clear aligner therapy or traditional appliance therapy, patients are going to relapse if they don't wear the retainer. So, again, for adults, this is normally with this clear aligner therapy, they need to be wearing the retainer at night forever. And I can't tell you how many patients come in where they broke it and it's been months and things have already. So it is really, really important, both in people right out of ortho and adults later on in life. The teeth will want to go back to where they came from. So it's important to wear that retention no matter what.
What age do you suggest referring to orthodontist for malocclusion?
Again, I think Dr. Kroll answered that pretty well. So, earlier is always better. It's hard to get time back once it's gone. So the sooner we get them to the orthodontist, I'd rather have the orthodontist say, it's too early, we're not going to do anything right now, than say, man, I wish you would have brought the kid in here a year ago or 2 years ago.
What age would you even intervene for an anterior crossbite in primary dentition?
I would have to look that up. I haven't dealt with that situation very much, but I think you can intervene with that pretty early.
Do you ever fabricate a splint for bruxism in children?
No, I don't fabricate splints for children and bruxism. To go back to what I said before, if it is sleep disordered breathing, the splint is not going to do much good. Again, kids are constantly growing too, so you'd be constantly making splints as well. So it's just not something that I do, and I don't work pretty close with some pediatric dentists, and I don't think they would recommend that in most cases either.
How does clear aligner therapy work when the permanent second molars are still erupting in adolescence? Will the trays give you an issue with fit as the patient is still developing?
So I don't do any clear aligner therapy. I'm in the Army, and so we don't really, outside of DIY, we don't use any of that software. I mean, our orthodontists do, but general dentists don't tend to. So I'm pretty sure though with the ClinCheck and some of these, having a brain fart right now, but ClinCheck would probably, it's going to look at the teeth and tell you, where things are going to be. So they're going to be designing a lot of the aligner. If those second molars aren't erupted all the way, I don't think the company is going to have the tray go to those teeth if they can't get retention on it.
At what age is it comfortable to give a splint to a child?
Okay, that's a good question. I mean, personally, I probably would not be giving a splint until they're adult, more of an adult, so 16 to 18, depending on they're a female or a male. And I'd want them to be in their permanent dentition at that point.
How often should Essex retainers be swapped out?
So again, that's kind of a patient-specific question. So, I mean, they can get pretty grody. I can make them for free, so I make them all the time. My patients can get one whenever they want one. In the real world, you're charging a couple $100s or more for one of these. So patients are not going to want them swapped out quite as frequently. But, unless they're breaking them, leaving them on the sun, treating them with cleaning them with household cleaners and things like that that are going to degrade the plastic, they really should last a while. But some patients are Bruxers and don't take good care of their stuff and may need them sooner, but I don't have a hard and fast number on that.
Okay, last question. Doesn't constant pressure from appliances such as a retainer put more pressure and cause root resorption?
So I don't know anything about retainers causing resorption. So whenever we do any kind of ortho, there is always a possibility for even a little bit of resorption. And then, we know some patients, even if we aren't moving the teeth too fast, we can get severe root resorption. When I talked about my other lecture the other day, the invasive cervical resorption, there's a lot of thought about that maybe ortho may be causing that as well. Now, the retainer shouldn't be putting any active force on the teeth anymore. And if they are, it's minimal. So say the patient, we'll talk about a removable retainer. The patient's not wearing it for a couple of weeks and they put it back in. There's going to be some temporary force put on there, but the amount that they've relapsed shouldn't be that bad that you're going to get resorption. Again, your fixed retainers, you really shouldn't be putting, there's no new force. The force from that wire is going to decay at some point, okay? Not to get into all the physics of it, but the teeth are going to resist it at some point, and there's going to be some energy in that wire, but over time that's going to dissipate and just hold them where they're at. So there shouldn't be any resorption from a fixed retainer. I will say this, I didn't talk about it with fixed retainers. If you have a braided lingual fixed retainer or maxillary and it breaks, you need to repair those right away. Braided wires have force built into them. So once that system, there's a break in that system, I recently had an orthodontist show me a case where a tooth was actually rotated, basically extracted, because that wire is twisted and has force on it. One of the anchor teeth broke, and then the tooth that was at the end of it now had rotational force placed on it and actually extracted it. So I'd say a lot of orthodontists really don't like the braided wires because of that. A mono wire, single wire is a little bit better option, but just something that I've seen recently, just to keep in your own mind. If you see that in a patient, you want to correct that immediately.